Hello, everyone. My name's Lisa Manning, and I work with WHO in Geneva. And today I'm going to be talking to you about behavioural and social drivers of vaccination. So in this presentation, our learning objectives are as follows. That we will understand the behavioural and social drivers, or BeSD, of vaccination, the framework and its domains and constructs. We'll describe the advantages of using the BeSD surveys, interview guides, and priority indicators. We'll talk about what tools to use to address what different challenges. We'll identify the opportunities and key steps for integrating the BeSD questions and indicators into program data collection activities or surveys or assessments, or when to supplement those existing activities with further surveys or interviews. And lastly, we'll talk about the main steps to using the BeSD tools and who to engage or involve in that process. So firstly, just to provide a little context for the use of these tools. As we know, routine immunisation coverage has plateaued in recent years, and programs have struggled to close gaps in coverage and equity. We've also seen the Immunisation Agenda, IA 2030, that to highlight demand and people-centred approaches and emphasise the importance of putting communities at the heart of program planning. We've seen that COVID-19 has led to a major shift for immunisation, with so much more new attention and awareness on vaccination and engagement of new prioritised populations as well, such as older adult groups and health workers. We've seen more attention on equity within and between countries, and also a lot of attention on hesitancy and reasons why people are not getting vaccinated in certain cases. And we also know that the causes of low uptake are poorly measured. They're rarely systematically measured over time and between countries. But at the same time, we've seen that our understanding of the reasons for low uptake and the associated evidence and expertise has truly evolved and come a long way in recent years. And as part of that, we're better able to understand the contribution of hesitancy in relation to those other types of barriers or drivers to vaccination. A lot of this work we also presented to WHO's Strategic Advisory Group of Experts on Immunisation, or SAGE, at its meeting in October 2021. And as a result of that session, there were a range of different recommendations to programs and to partners to be using these tools systematically for data collection and as part of planning processes. So what are we measuring? We have four main behavioural and social drivers that contribute to vaccine uptake. The first is thinking and feeling. And this is where we situate attitudes or vaccine confidence, and that includes the perceived benefits, safety, and trust in vaccination. There are the social processes or influences, and these relate to social norms, such as the influence or support of family members, friends, and community leaders or religious leaders. It's context specific. There's also health worker recommendations and other gender or equity related barriers as well. There's also, thirdly, motivations or intentions, the willingness to want to get the recommended vaccines. And lastly, if not most importantly, the practical issues. And this includes availability, affordability, ease of access, service quality, and the experience in getting vaccination. This includes also the respect or interaction with a health worker. So these four domains unpack further into various constructs or themes And we use this as a basis for measuring the different drivers of vaccine uptake. And this enables us to know that we're measuring all of the right domains or constructs as we carry out surveys or interviews. This enables us to ensure that we're gathering all the necessary data to be able to fully understand these issues. And we develop this framework based on the evidence and expertise and the findings of our field testing and validation process that we went through with our working group over the recent years. So where do we situate hesitancy? This has also been a topic of a lot of focus in recent years. And like I said, it's important to note that hesitancy is part of the motivation domain. And we define hesitancy as a motivational state of being conflicted about or opposed to getting vaccinated. This includes these intentions or willingness. And it's very important to accurately define hesitancy so that we're able to effectively respond to it with the appropriate tailored and targeted strategies. So what are the tools and guidance that we now have available on behavioural and social drivers? We have a set of tools for childhood vaccination, a survey for parents of children under 5 years, and also qualitative tools or interview guides targeted to parents, health workers, community stakeholders, and authorities. And for the COVID tools, we have surveys targeted to adults and health workers, and also qualitative interview guides as well. And these tools come with practical, very user-friendly implementation guidance, which covers the process of thinking about how to plan to gather this data, how to collect and analyze the data, and lastly, how to present the findings and use this data on an ongoing basis as part of these program planning and implementation processes, and also how to use the tools for monitoring and evaluation of different interventions. So why is it important to measure the behavioural and social drivers? So it's not only about understanding why there is low uptake and these main reasons. It's also about being able to gather data on trends and the various issues that are facing programs, these reasons for low uptake, but also to be able to have better data to inform the design and evaluation of interventions. And the data can be used for policy making, planning, for evaluation, for allocating resources, and the data can be importantly shared with other program partners and stakeholders to enhance a common understanding of what these issues are and the corresponding actions that are needed to be taken. The data can be used as part of various kinds of training activities, and it can be used as a basis for dialogue and conversations with program stakeholders and partners, community representatives, to get the right people around the table to be addressing these barriers as well. We've also included these measures as part of Strategic Priority 2 of IA 2030, so that at a global level, we're also following the number of countries that are gathering data based on use of these measures as well. So a quick word on how the tools were developed. I will not go into all of the detail on this slide, but in short, to say the development process followed 4 main phases. The tool development process, where we looked at a lot of the evidence, we carried out interviews with our end users, and we also did some initial tool development, and that included our demographic items. We then went into a field testing phase that included translation of all of our tools and materials. We did some cognitive interviewing, and that was to ensure that the survey or interview participants had a common understanding with the interviewer about the meaning of the questions and response options. And we also had some follow-on conversations with the interviewers in the field testing process to also get their feedback on how the tools worked in practice. We then went into our validation phase where we implemented the surveys and carried out psychometric analysis. And that's where we looked at important factors such as the performance of various items in implementation and what questions gave us the best information and were most comparable between different settings. And we then used that data to inform the finalization of all of our tools. And lastly, we completed the guidance that we have for use of these tools as well. Throughout this entire process, we had an ongoing dialogue with various kinds of end users for these tools as well. So that includes partners, colleagues, and different program implementers or decision makers who also would be using the tools or data in their work as well. And they were important contributors to also helping inform the finalization of these tools. So what are we measuring? This table provides a more detailed overview of the different constructs or themes that we're measuring. And this is just the example for our COVID vaccination survey. And importantly, each box notes a different construct or theme that we're measuring. And the constructs in red correspond to questions that are our priority questions in the main survey. And these are the questions that we recommend being used on a systematic basis and avoiding any revision to these questions as well, so that the questions and response options can be used in the most standardized way possible for comparable data at a country level, a local level, and globally. So these ones in red are really the most important, and they can be used as a short form survey. And the ones with a coloured in circle correspond to all of our other survey items. And here we have our demographic items as well. So this at a glance provides a summary of each of the constructs and corresponding questions in our survey. And just to take a quick closer look at our priority indicators, like I said, these are the ones that we recommend for consistent and standardized use as much as possible. And as an example, here are what the questions look like. So in the last row here for practical issues and the affordability question, the question is, how easy is it to pay for vaccination? When thinking about cost, please consider any payments to the clinic, the cost of getting there, plus to the cost of taking time away from work. So would you say it's not at all easy, a little or moderately easy, or very easy? And this is just to give you a sense of the simplicity of these questions as well, how easy they should be to ask, how easy they should be to translate as well, and easy to answer for the different respondents. And in the right-hand column here, you can see the corresponding indicators that can be used as part of the reporting and tracking process. We have similar priority indicators here for childhood vaccination as well. Perhaps you can come back to this and see that these are harmonized so that we can also have some comparison between our childhood survey questions and the COVID questions as well. So just to give you a couple of brief summaries of some of the data that we've gathered in the last few months. So this is just to offer a little snapshot or summary of how the data can be presented. So this is an example from Ethiopia when we do look at our priority indicators, or these 5 priority questions. And we can see here that there's high confidence in the benefits of COVID vaccination. The norms are a little lower. They're perhaps not yet established, but they are much lower for adults compared to health workers. The intentions are quite high. We can see here that still the majority of people do want to get a COVID vaccination. And there's good knowledge about where to get vaccinated, even if this is lower for adults compared to health workers. And affordability is actually quite low, that only about 3/4 of respondents say that vaccination would be moderately or very easy to pay for. Here's also an example of some data that we gathered from South Africa, also on COVID vaccination. And here we can see that the practical issues, only 19% of our respondents said that vaccination would be very easy to access. And we can see that the corresponding actions taken, including an expansion of the sites where vaccination was being offered. They shared more information about those sites and where they were located and the timing of the services. And they also shared more explainer videos on how to register for vaccination and where to go and how to get there. So this offers also an overview of each of the main findings in our 4 domains and the corresponding actions taken. And again, I won't go into any of the detail here, but you can see this at your leisure at a later date. I also have an example of rapid data collection from the Congo Republic. This data was gathered in April this year, and we can see the stratification of findings across the different responses to our motivations item, whether someone would want to get vaccination, they do, they're not sure, or do not want to get the vaccine. And we've stratified these for the importance question in the confidence domain, whether people think vaccines are important or not, whether people think that vaccines would be easy to get, and whether most people, whether they think their peers, their friends or family members would also want them to get vaccinated. And this provides an important breakdown of these different types of questions corresponding to willingness. And we can see, for example, in our lower left-hand corner here, that for people who do want to get vaccinated, yes, their peers, their family and friends also want them to get vaccinated. But if they're not sure or do not want to get vaccination, we can also see that that plays out with their peer groups as well. And just to summarize here, we can see that from the findings and a lot of other findings that are not presented here, the main challenges to vaccination here were that the local facilities did not have doses available. Services were too far to go. Most people didn't know where to go. And also a lot of people were not sure if they were eligible. So most of the barriers here were really related to accessing vaccination and the ease and convenience of vaccination as well. There was also low risk perception, so people were not convinced about the need to get vaccination, and there were also lingering concerns about the effectiveness and safety of vaccination as well. So like I've said, this is not only about gathering data to better understand the reasons for low uptake. It's about the interventions and actions that then take place, and also being able to carry out the necessary monitoring and evaluation on those interventions as well. So as part of the work that we carried out with our working group in recent years, we also developed this table with interventions that we identified based on a scoping review and with expert inputs. And we organized these interventions to correspond to the domains where the problem is identified from our BeSD framework. And here, this is an easy way for program partners and colleagues who are gathering this data to have a direction of thinking about what kinds of interventions would correspond to those issues and where they need to be moving to think about what kinds of interventions would be most effective to act on those barriers. Monitoring and evaluation of interventions is also absolutely critical to establish whether they're being effective, whether there's continued improvements that are needed on those interventions. And so in our guidebook, we've included this summary table to offer an indication of the different kinds of measures that could be needed for various interventions. So if we're talking about practical issues and um, uh, uh, indicators of the percentage of adults or healthcare workers who know where to get vaccination for themselves, the interventions here might include improving access or mailing or phoning an offer of an appointment or carrying out reminders or outreach. These are examples of the different kinds of interventions that could be implemented to overcome these access-related barriers. We can then see what the inputs would be for those interventions and what the activities would be, and then the outcomes that we would want to be measuring against those different interventions. And this is also to help programs and partners and our users of these tools to have a quick and easy direction to take when they're thinking about monitoring and evaluation and what factors to be assessing in implementing different interventions. Now, like I said, WHO's Strategic Advisory Group of experts on immunization reviewed all of this work in October 2021 and issued a series of recommendations to programs and partners to be systematically gathering and using this data to understand reasons for low uptake and to be tracking trends and carrying out monitoring and evaluation. These recommendations and a summary of this entire body of work over the last 3 years of the whole tool development and testing and validation work is summarized in this position paper. Excuse me, please. We need some water. Excuse me, thank you. So all of the findings here are summarised in our position paper on behavioural and social drivers, which was published last month, and the link to this paper is available here. So where do we start when we're thinking about using these tools for gathering local data? The first step really is to think about who needs to be involved in the data collection process. We then work with these various stakeholders to think about what are the problems, what are the biggest questions that we have, and then start to think about the methods. Are we going to have to do a survey, some qualitative interviews, and how are we going to gather and analyze that data? We then think about the further details on data collection methods, the prioritized population. Will it be, for example, nationally representative or targeted to a specific district or region? And then we look at our tools. We think about how we might do some local adaptation and pre-testing of the tools to match these local needs and objectives. And then we develop a little plan, which includes timelines, the budget, a process for how we're going to be gathering and using the data and associated methods. And then we also think ahead a little bit as to how we're going to be using the findings and who needs to be involved in looking at the findings and using that data as part of planning implementation processes, and then also follow on monitoring and evaluation of the subsequent interventions to think about what might need continued improvement and ongoing evaluation. So we hope that these main steps help to set you in motion in thinking about what are the main steps to really be using these tools in different ways and who needs to be involved. Now, when it comes to research, also a few top tips here to help you get started. And this is really just some main suggestions. I'm sure if you're talking with other research experts, they will have a lot of other ideas, but this is just intended to help set you in motion. So think about what your research objectives are. For example, what are the main populations where we have the biggest gaps in vaccine uptake and coverage? We need to think about the people that we're going to be participating in the survey or interviews, and think about translating and testing our questions. So maybe there's a little bit of local adaptation needed for the local cultural context or local languages. And it's important to note that we should not be changing the question wording or the wording of the response options unless there's a lot of insights gathered in the testing process that indicates otherwise. And this is really important because it, using the questions and response options as they've been designed will enable us to have comparable and standardized data. And if we make some changes here, this reduces the comparability, perhaps over time or between different settings. So reduces the potential for a broader impact on using this data. It's important to think about the demographic questions for the local setting, maybe thinking about the education level, the literacy, and also some of the socioeconomic considerations for the participants. We also need to know that we should avoid convenience samples. We really want to have quality data that's representative of a specific population group. And it's important to note that there are ways of gathering quality data in representative ways that is efficient in terms of time and budget. And please reach out to researchers and experts that you know who can assist with these methodological considerations. And lastly, do not go overboard in using lots and lots of questions. Really think about using the questions and measures that will give you data that you're going to use as well. And this might be an iterative process. So perhaps in some settings, starting with a survey or perhaps a shorter version of this survey, and then based on the findings there, really zooming in to a particular population group or district or geographic setting, and then using that to think about what further data would be needed. So where to find these tools and guidance? Here are 3 links to take you to our tools and guidance for childhood and COVID vaccination, our position paper, like I mentioned previously, and also our vaccine demand webpage, which also has a lot of other tools and guidance that can help in implementing different kinds of interventions, thinking about service quality and the experience of getting services that are meeting people's and community needs. And lastly, we have tools on tailoring immunization programs and human-centered design. This is also for targeted, tailored approaches where there's low uptake in specific settings. I will end our presentation there and be very happy to take any further questions or comments in the discussion as well. So thank you very, very much for your attention, and look forward to continued engagement here as well. Thank you very much. Goodbye.